Welcome in Pediatric Lecture Series. Myself, Dr. Sunil Natha Maske, Professor in Pediatrics and Dean in Dr. Vittal Vike Patil Foundation's Medical College and Hospital Ahmednagar. In this Pediatric Lecture Series, next lecture is on the thyroid gland of the children. In thyroid gland of the children, congenital hypothyroidism is very common, which come across in practice as well as in exam also. Introduction. Hypothyroidism is a condition in which the thyroid gland does not produce enough thyroid hormones, which control overall metabolism and many bodily functions. In this hypothyroidism, there is a one subcategory which is known as Hashimoto's disease. In this Hashimoto's disease, body's immune system mistakenly destructs its own thyroid gland. That means auto-destruction of the thyroid gland occurs. Next type is congenital hypothyroidism, which is name itself suggests it is present at birth, and it is a condition of thyroid hormone deficiency which is marked by arrested physical and mental development, dystrophy of the bones, soft parts, and lower basal metabolism. We will see in details of congenital hypothyroidism very soon. Next one terminology is the mixed edema. Mixed edema is the acquired form of hypothyroidism. And this hypothyroidism, mainly congenital hypothyroidism, occurs 1 in 4,000 of the newborns. This congenital hypothyroidism has a certain risk factors like chromosomal disorders, for example, Down syndrome, Williams syndrome, or Turner syndrome. Also, an autoimmune disorders such as type 1 diabetes or celiac disease, along with injury to the thyroid gland, are the risk factor for congenital hypothyroidism. Now, there are certain associated syndromes with congenital hypothyroidism, like Pentard syndrome, Bamforth-Lazarus syndrome, brain-lung thyroid syndrome. Sometimes this congenital hypothyroidism has a genetic origin. When it is inherited, the condition usually has an autosomal recessive inheritance pattern. That means both copies of gene in each cell have mutations. Typically, the parents of an individual with an autosomal recessive condition will carry one copy of mutated gene, but they do not show signs and symptoms of the conditions. These are the genetic variation and type of gene involved in this condition are mentioned in this table. Now, etiology. The most common cause of congenital hypothyroidism is failure of a thyroid gland to grow before birth. It may be due to just we have seen genetic. Second one, iodine deficiency. Third one, defect of development of thyroid gland. Fourth one, presence of maternal antibodies. Fifth one, maternal intake of certain drugs like radioactive iodine, iodides, propylthiouracil, methimazole-like drugs. And many times it may be idiopathic. Now, clinical features. Clinical features of hypothyroidism, which is present at birth, that is the congenital hypothyroidism, are very important because it is the one form of mental retardation which you can prevent if you detect and treat properly. So in neonatal period, there will be features of pallor and hypothermia, enlarged tongue, hypotonia, prolonged physiological or pathological jaundice in newborn, rough and dry skin, open posterior frontally, child has a constipation, mild post-maturity, and these are the large baby. These are the very typical clinical features which you have to identify in the neonatal period, that is within the first month of life. Also, these features will carry on after 1 month of life, but some of them may be additional like umbilical hernia, pallor and hypothermia will be carry on. Large tongue which protrudes through the normal mouth, it is very diagnostic and characteristic of congenital hypothyroidism. Rough and dry skin, Baby will manifest as a constipation. There is a facial puffiness. After 1 month, child has a growth retardation, poor development. He may develop myxedema and also have typically umbilical hernia after 1 month of age. These are the physical features. Now we will see the skeletal features. In skull, one will see the delayed closure of frontanelli, also mainly posterior frontanelli, relatively large sella turcica, poorly developed paranasal sinuses, brachycephaly, delayed dentition and dental caries, and presence of Wormian bone in skulls. Also, you will see dwarfism and increased density of bones in the skeleton. There is a retarded growth, multicentric and irregular epiphyseal center ossification, delayed fusion and stifled appearance. Also, there is epiphyseal dysgenesis. It is known as fragmented epiphysis. Spine shows kyphosis, flattening of vertebral body, increased width of intervertebral space, bullet-shaped vertebral body, especially in the L1 and L2 vertebra. Long bone shows short limb dwarfism, dense transverse bands at metaphyseal ends, and pelvis shows narrow coxavera. In short, signs and symptoms of this hypothyroidism will manifest in the form of psychological, in the form of poor memory and concentration, poor hearing, hoarseness of voice, bradycardia, pericardial effusion, delayed reflex and relaxation. Extremities are cold, carpal tunnel syndrome child may complain. In general, there is a fatigue, feeling of cold, weight gain and poor appetite, hair loss, shortness of breath and pleural effusion. In skin, there is a paresthesia and mixed edema. There is a constipation and ascites. And in girl, she has a menorrhagia. Diagnosis of congenital hypothyroidism is very, very important. On 5th to 7th day of postnatal life, you have to do the estimation of T3, T4, and TSH. Before 5 to 7 days of life, it is not done because of maternal hormones and antibodies. At these days, TSH level is more than 20 milliunits internationally. Now, we'll again repeat the radiological changes which we have seen in the skeleton category. These are shown in the X-ray also. Widely open anterior and posterior frontanelli, depressed nasal bridge, retardation of osseous development, absent distal femoral epiphysis at birth, large skull with wide sutures and cortical thickening. See in this skull, you see the cellular view showing enlarged sella hypoplastic maxillary and frontal sinuses. It is shown by arrow. Now in the wrist and in hand, X-ray of wrist showing bone age of 10 years child, where chronological age is 24 years. In figure in X-ray, we have shown epiphysis of pisiform just appearing at 24 years of age, which is corresponding to 10 years. Second arrow shows irregular ossification of growth plate. Third arrow, which shows sclerotic band at radial metaphysis. Fourth arrow shows soft tissue thickening. And fifth arrow showing pencil thin cortex of the long bones. Now this is the X-ray of the spine. We have seen bullet-shaped vertebra, especially L1 and L2. Then osteoporosis is shown by number 2 arrow. And third arrow shows increased intervertebral spaces. Also, we have seen X-ray pelvis, which shows in first arrow unfused femoral head of epiphysis, whereas in second arrow, it shows unfused apophysis. In third again, it shows pencil thin cortex of long bones, and fourth showing persistent triradiate cartilage. This is the X-ray of knee showing heterogeneous epiphysis with irregular ossification of growth plate. We have seen these clinical and physical and radiological features of congenital hypothyroidism. Now we have to differentiate this congenital hypothyroidism from goiter, Down syndrome, skeletal dysplasia, biliary atresia, hypopituitarism, iodine syndrome, pituitary dwarfism, panhypopituitarism, and metabolic storage diseases. It is very, very difficult to clinically differentiate this, but with the help of proper observation, radiological and clinical features, one can easily differentiate all these conditions from congenital hypothyroidism. Now, complication of congenital hypothyroidism. If we don't identify the condition at proper time, don't diagnose and don't treat it, the child will surely land up into the mental retardation, impairment of linear growth, impairment of bony maturation, gait abnormalities. Child may have spasticity and dysarthria. Child also have mutism and autistic behavior. These complications all are avoidable if you start proper treatment and diagnosis. Treatment in congenital hypothyroidism is always given in the form of synthetic form of thyroxine, that is the thyroid hormone T4, commonly used is a levothyroxine. Dose of levothyroxine in child is 4 microgram per kg weight of the body per day, whereas in adult it is 2 microgram per kg per day given orally. If you give long-term and excess dose, child may manifest side effects of levothyroxine in the form of craniosynostosis and or pseudotumor cerebri. Very important instruction while giving the levothyroxine that don't mix this drug with soya formula or calcium or iron preparation because it decreases its absorption. You may give the proper dose, but still you will not get the proper result. That's why one should not mix levothyroxine with calcium, iron preparation or soy formula. Prognosis of congenital hypothyroidism. Most of the children born with this disorder and correctly treated with thyroxine, growth and development occurs normally in all respects. Even most of those with athyrosis and undetectable T4 levels at birth develop with normal intelligence, although as a population, academic performance tends to be low that of siblings and mild learning problems can occur at some age. In short, congenital hypothyroidism is the most common preventable cause of intellectual disability. Now, we have to evaluate this as a screening program. Serum T4 or free T4 or TSH blood test should be performed at second and 4 weeks after the initiation of thyroxine treatment. Also after that, every 1 to 2 months during the first 6 months of life, you have to do the thyroid hormone estimation. After this life, every 3 to 4 months, between 6 months to 3 years of age, you have to do it. Then after that, till the growth is completed, every 6 to 12 monthly, you have to repeat the serum T4, 3T4 or TSH along with all the thyroid profile regularly. Now, we will see the newborn thyroid screening. This in many places done routinely. Blood sample is taken by heel prick of the newborn baby. For early diagnosis and proper treatment of thyroid disorders in children, this screening program is very, very important and it is one of the treatable and preventable cause of intellectual and mental retardation in child population. Now, National Iron Deficiency Disorder Control Program is a national program which is launched in 1962. The objective of this program was reducing and preventing iron disorders in control group of this program. To assess the magnitude of the iron deficiency disorders, to supply the iodized salt in place of common salt, laboratory monitoring of iodized salt and urine iodine excretion. And this program mainly focus on health education and publicity. And the main goal of this National Iron Deficiency Disorder Control Program was to decrease the prevalence of goiter below 5% in school children in the age group of 6 to 12 years of age. This is the very short but very, very important topic which is seen just now as a congenital hypothyroidism, which one should take home message that if properly diagnosed earlier and treated properly with proper follow-up. This is one of the preventable cause of intellectual and mental retardation in child population. Thank you.